join the wrong meeting. Hopefully he'll get on and join the right one.
Hello, the meeting is now live.
Lovely, thank you very much. We are waiting for 1 or 2 people still to join us, but I will start with the housekeeping. So welcome to our governing board meeting held in public. I am Dr. Elizabeth Fellows, chair of the governing board. We're meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available on the website. Papers for the meeting are also on the CCG website. Today's meeting is being recorded so that in the event of failure of technology, it may continue and will be uploaded to the CCG website as soon as possible. Bookmarks have been added to the pack of papers in order to identify agenda items. Members of the board, you're asked to keep your cameras on where possible, mute your microphones unless you're called to speak. Please only use the raised hand or chat functions to indicate that you wish to speak, as any typed comments can't be viewed by the members of the public. I will ask people to introduce themselves, giving your role. So we'll go down my list. Actually, before we do that, we will introduce and say welcome formally to Maggie McIsaac as our new accountable officer. But Maggie, can you give your full title?
Thank you. So my name is Maggie McIsaac, and from the 1st of April, accountable officer for Portsmouth CCG, and delighted to be part of the board now. Thank you very much.
Thank you.
Was that Helen? Huge apologies. I can't hear you. You seem to have gone on mute, Elizabeth.
Right, yes, Helen. We'll
Yes.
work down the list. Now we've done Maggie.
Apologies for being slow. I'm Helen Atkinson and I'm the Director of Public Health for Portsmouth.
Karen.
Hello, I'm Karen Atkinson. I'm the governing board nurse for CCG.
Linda.
Hi, I'm Dr. Linda Colley, GP and clinical lead for Health and Care Portsmouth.
Margaret.
Hello, I'm Margaret Geary. I'm a lay member at the CCG.
Alison.
Hello, Alison Jeffrey, Director of Children's Services for Portsmouth City Council and lead for Children's Health Commissioning for the CCG.
Carsten.
Hi there, my name is Carsten Shaft. I'm a GP in Southsea and I'm one of the clinical execs for Portsmouth CCG.
Graham.
Hello, I'm Graham Love and I'm a lay member.
Jackie.
Hello, I'm Jackie Powell, another lay member.
Dave.
Good afternoon, David Scarborough. I'm the practice manager representative for the board.
Andy.
Good afternoon, Andy Sylvester, lay member.
Simon.
Hello, I'm Simon. I'm a GP in Portsmouth and I'm also one of the clinical execs.
Michelle.
Hello, I'm Michelle Spandley. I'm Chief Finance Officer.
Tawinda.
Hello, my name is Tawinda Uppal. I'm a secondary care consultant.
David.
Hello, I'm David Williams. I'm the Chief Executive of Portsmouth City Council and a board member of the CCG.
And Joe.
Hello, I'm Jo York. Managing Director for Health and Care Portsmouth across the CCG and the Council.
And welcome, because this is your first board meeting as well in your new role. So welcome.
Thank you. Thank you. Delighted to be here. Thank you.
Yeah, it's great. So we also have Bernie Allen here for an item in the agenda. Bernie, do you want to introduce yourself?
Thank you, Elizabeth. I'm Bernie Allen. I'm the Deputy Director of Planning and Analytics. I'm here to support agenda item 7, discussing the planning update for 21-22.
Lovely, and thank you for coming along. Jane.
Hi, I'm Jane Collis, Business Development Manager, and I'm taking the minutes today.
And Justina.
Good afternoon, I'm Justina Jeffs, Head of Governance of the CCG.
Lovely. Thank you very much. So we've got new members to the board, and we have Linda Colley, who has been our accountable officer and chief clinical officer from 2017 until March this year. But we're very pleased that she's still here as in her new role as clinical leader. So that's really good news. Sadly, we are going to be saying goodbye to Alison Jeffries, and this is Alison's last board meeting. We are really going to miss you, Alison. You have been invaluable in developing the integrated children's work for the city, but we completely understand why you'd be wanting to move back to a job next to your home. So we wish you all the very best for the future, but you will be sorely missed.
Thank you, Elizabeth. I shall miss Portsmouth too.
Good. I'm pleased you will. Perhaps you can take some lessons away from here. So, right, we've got apologies from Nick Moore. If I didn't say that, I can't remember now. So, moving on, we've got register and declarations of interest. So, we know that we need to be adding Maggie to this list. And that will be done. Joe is already on as a person on the register. Does anyone have any other changes to mention? And sorry, Maggie.
Yeah, just to confirm, the paperwork will come through, Justina, but actually my conflict of interest forms will show that I haven't got any conflicts to declare.
Lovely, thank you. That makes it nice and straightforward. And does anyone have any potential perceived conflicts of interest for this meeting? No one's got anything. Lovely. Okay. So we will note those changes and get that updated. So minutes of the previous meeting. This is from Wednesday, the 17th of March. Does anyone have any comments or updates, or not updates, any comments or corrections for these minutes? No. Well done, Jane. That's good stuff. If we can then move on to the summary of actions, which is paper 3B. I think we've got updates on everything. Have people got any questions or comments on these updates? Jackie.
Hiya. So with regard to the planning approach on 7D, I think there may be another case that we hope to get to that board development that's still outstanding, that I'm thinking may be coming back at some stage, which was the ADHD waiting list initiative. Is that making sense?
Yes.
I can see other people nodding, but yeah, you may not.
Yeah. Justina, I know there was a conversation had.
Yeah, I just think it needs some further work with the finance team on that one. So we do have it in our site.
Lovely. Thank you. So not forgotten, Jackie.
Thank you.
Okay. Any other comments or questions about these? That's nice and swift. Thank you. So, try not to miss an item out. Item 4 is Health and Care Portsmouth COVID-19 update, and this is verbal from Helen.
Thank you, Elizabeth. And as usual, I'll just share some slides. I'm on full. Okay. So I'll just be covering quickly the vaccination uptake levels in Portsmouth. current COVID infections, variants of concern or under investigation, because I'm aware there's quite a lot of interest in that at the moment, and hospitalisations and deaths. So we are obviously very much in a very successful NHS vaccination programme currently for COVID-19, and this is the current results. They're slightly out of date because we have to wait a few days, although I'm pleased to say as of today we've now getting a daily national website link which has the up-to-date data that all of our residents patients can access, and it has really helpful data on uptake by up to local authority with good comparators of other areas. So you'll see here that we're currently at about 48.1% of our whole population have received one vaccine, and we've got 54,150 having received both vaccines. And then on the right hand side you'll see the colour code with the percentages that relate to the graph below. You'll see that we have got good uptake in our older age groups from about 65 upwards, and we've got some really impressive for vaccination programs uptake there of well into the 90%. And as we come down lower, of course, it's important to note that some of these age groups are only at the first stages of being offered invites to come and have their vaccinations, but it's all looking quite healthy, and we are at the stage where I think we are this week where people under 40 being invited, and I think by the end of this week we're expecting people 35 and over to be invited. So we continue, we're not complacent, we continue at the NHS continue to work really well with partners to be inviting everybody that is able to have the vaccination in the cohorts, and we continue to see good uptake and quite a lot of focus also, just to say, going on around encouraging those who've got vaccine hesitancy, and particularly some of our more vulnerable groups who are at greater risk from COVID, to try to work with community groups to access and increase uptake in those groups. Just want to stress how important it is. I'm going to come later in the presentation to talk about the variants of concern, particularly the Indian variant, but there's no current evidence that any of the vaccines currently being offered are not effective against any of the variants of COVID. So it's really important that we encourage as many people to take up the offer vaccine as we can. Then moving on, this is our normal spark lines which show a comparator. So you've got there the total number of cases and new cases in the last 7 days for each of our areas in Portsmouth, Southampton, Hampshire and Isle of Wight. We currently have had 36 new cases in the last 7 days in Portsmouth, and I'm going to go to the next slide, which is a more helpful comparator because it's because we've got different size populations. It's important to do the rates per 100,000. So you'll see there on the left hand side is the current England map, and you'll see particularly there a small part of London, Midlands, but mainly in the northwest of the country we are seeing increasing rates again, and that is mainly down to the Indian variant. But again, looking importantly across our local patch, we've got really good rates per 100,000, quite low still. So the Isle of Wight at 8.5, Portsmouth at 16.8 per 100,000, Hampshire at 12.3 and Southampton at 28.5, which all compare well to the southeast average of 12.3 and England of 21.2. Just wanted to put in there a good comparator, which is the current situation in Bolton, which, as you know, is kind of the epicenter of the Indian variant increase in case at the moment, and they are at 283.1 rate per 100,000, which is significantly higher than we're seeing locally, which is important, but was also probably at the kind of rates we were seeing in the midst of the second wave. So just wanted to share that. Then quickly just looking at our age bands, this is all age bands, and you'll see, which is important and good to see, that we're coming very much, we've come very much down in terms of the epi curve. Rates are now pretty low across all age bands, but where we are seeing, I suppose, the highest, if you can just see there from the graph, it's in our 30 to 40-year-olds, which, as you know, are the age band that are only just being offered vaccinations. So I think that's quite an important point. And then we always, just because it's important to actually show the younger age bands as well. So these are around school age there. So rates are currently very low for children of primary school age and below, and rates are higher in secondary age pupils, as you would expect, because there is more testing in that group of young people, but numbers still are fairly low, but do fluctuate with a few cases. And just as an example, this week we have seen a few linked cases in schools this week, so we expect that to fluctuate a bit, and we do expect to see an increase in cases anyway as we move slowly out of the Prime Minister's roadmap lockdown. And obviously we've gone into step 3 only just this week, but step 3 now this week. Then just wanted to, as I said, I'd mentioned the variants of concern or variants under investigation. So sorry, this is quite a busy table. So the bit I want really to focus on is that on the bottom right hand side there, you'll see the red box. This, just as an example, this is the Indian variant. This is national data, not local data, I should say. But this shows you that we have seen quite a rapid increase in Indian variant cases, particularly, as I said, in the northwest. So a week ago, you can see just about there, it's at 793 cases now. A week ago, it was in the 300s. So we are seeing quite a significant increase in cases, particularly in that part of England. And just to put that into context, so I just want to give you assurance, we are not currently seeing any cases of Indian variant in the Portsmouth area. And we have had, since the beginning of the pandemic, and that we've been doing the genomic sequencing or typing, we've seen 9 cases of variants of concern or variants under investigation, none of which have been the Indian variant, and all of which have been travel related and have been quarantined and supported locally. So there's been no further spread or community spread. However, it's important to note that there are cases of the Indian variant and of community spread in the southeast, across the southeast, and quite locally in which you'll know from the media coverage in Southampton and Hampshire. But mostly in the southeast, we're seeing variants of concern in the areas that surround London, because London is also a bit of a hotspot currently, around Surrey and Berkshire and Buckinghamshire. And then just to focus quickly on pressures in our hospitals, and this is for our Portsmouth Hospital University Trust. So looking really good. You can see there on both of the graphs, we've only had 2 admissions and 4 inpatient diagnoses for COVID-19 in the last 7 days, and currently 20 total beds at QAH, Queen Alexandra Hospital, occupied by COVID patients, and 1 patient in ITU, which is obviously a much better situation than we have seen for many months over the wave 2. And again, just quickly looking at deaths, so there's been 1 death in the last 7 days, but 369 deaths in total in Portsmouth. And then just finally, to put that into a context, I know this is quite a complex table, but just on the table at the bottom, you'll see that the bars relate to all deaths. And what we do is we look at the average, or what we call excess deaths over the period. So the green diagonals at the bottom, diamonds, sorry, are the expected average you'd expect to see. The grey are all bars are all deaths, and then the red are COVID deaths. So you see again there, we have not had excess deaths for some time, and certainly not from COVID. So that's the end of the presentation, and I'll stop sharing the slides. So I suppose my overall message there, though, is that stop showing the slides, is although I recognise that there's been a lot of media attention around, particularly in the Prime Minister's announcement last Friday, around variants of concern, specifically the Indian variant, it's important to note that numbers locally in terms of our infection rates stay very low. There is no current evidence, and that's obviously the work that's underway at the moment to look at research to be able to give us a better picture, but there's no current evidence that, as I said earlier, that the current vaccinations are not effective for any of the variants, particularly the Indian variant. There's no suggestion that the Indian variant, in the cases that we're seeing increased cases in the northwest of England, are translating into pressures in the NHS and hospital admissions or ICU. But what we do know is that those that are testing positive for Indian variant are those that have not been vaccinated and are in our younger population. So I suppose it's really important to continue to really encourage everybody to have vaccination. I've said that several times now, sorry, I'm like a broken record, but also to maintain, as we're moving out of lockdown, with all of the prevention messages, the hands, face, space, fresh air, and not to be, I suppose I call it, we're looking optimistically cautious, so to continue to be cautious, and I think that's where we are. But just to say, we are aware that there is quite a lot of discussion, and it is highly possible that step 4 of the roadmap might be changing slightly because of the increasing cases in the northwest of England. And I'll finish there, Elizabeth.
Thank you very much. It's a very rapid canter, but some reassuring news for our local figures. So, any questions or comments for Helen? Jackie.
Thank you. That was really, really helpful. And it was a very simple question: is what is step 4? And does it stop going on holiday?
So, Jackie, that's a very good question. So I'm very happy to send you a very easy guide to the 4 steps from lockdown. But basically, in June, which is step 4, it is going back to everything being open. So, as you know, step 3, which happened on Monday, was the ability for all our residents, population of the country, to start going inside restaurants and pubs to eat in a COVID safe way, but also obviously many other things are happening in each of those stages, but I suppose that's the one that most people were aware of. And as David has put in the chat, compulsory hugging. Well, I'm going to say cautious hugging. It's always good, and we put it out in the media. I realise people have, it's been a huge impact. I mean, gosh, we've never been through such a difficult year in a bit, because it is now well over a year. But obviously, what we wouldn't be encouraging is people to be hugging people who are vulnerable, unvaccinated, and likely to be at higher risk from COVID. So it's cautious hugging of those that have been vaccinated and are more likely to be safe. So, but I do recognise hugging is very important to some people, not to everybody. So I think we will see, Jackie, I suppose, because from the end of June, it was basically, I know some people saw it as going back completely to what normal life was before COVID. I don't think it is, I'm afraid. I still think that we will be having some, some public health messaging, but I think it might be changing. So I think we expect to see some change in caution for step 4.
Thank you very much. It's very helpful.
Right. Any other comments or questions to Helen? Well, thank you very much, Helen. It's as comprehensive as ever and very useful to know where we're at. So thank you. Something I missed at the beginning, I need to announce that Maggie will need to be leaving the meeting by 3:30, and David will be going by 4 o'clock for prior commitments. So that's the agenda has been planned around those times for them leaving. So Moving to item 5, we've got the CCG executive report, and this is to be presented by our new managing director, Jo. If you like to.
Yeah, thank you, Elizabeth. This report is a sort of summary of the executive team, management team activity since the last board meeting. And there's just a few points that I would like to draw the board's attention to, or where there have been updates following the writing of the report. And they're predominantly on page 4 and item 7. So just to bring the board's attention to the fact that the CCG has published its statement of compliance against the mental health investment standard. So important that we're aware of that, and just wanted to highlight that we have achieved that. Item 8, the review of governance arrangements and the CCG operating model. Board will be aware that we had been seeking legal advice on how we make sure our further integration with the council keeps us legal as a statutory body, and that we have the right mechanisms in place to enable that continued working and integration with the City Council and that shared executive team across Health and Care Portsmouth, but also that we're doing all the things we need to do as a legal body, as a statutory body, and that the accountable officer role for Maggie is assured, and that all works in a legal way. So we've received that legal advice from Bevan Britton. That's been shared with the board. That gives us a very clean bill of health around that everything, the legal mechanisms are all okay. So if the board is happy that signs off the piece of work that was commissioned by the board in October, we will continue to ensure that we proceed in that way, and that we will sign those legal documents around the section 113. That's the mechanism that allows that further integration for Health and Care Portsmouth to continue, and that we will then bring back to the next meeting of the board the revised and updated scheme of delegation. So that will be finalised as well, and we'll continue to work on the Health and Care Portsmouth prospectus and share that with our partners in the city and in Portsmouth, South East Hampshire and the wider ICS, so that people are clear how we're operating over this last year as a CCG. This next year as a CCG, sorry. So that was that one. And then the final one I just wanted to draw the board's attention to in terms of an update is around the local elections. So those results have now come in, and the Gerald Van Jackson continues to be the leader of the City Council. However, we have had a change in portfolio holder for health and care, and so we'd like to thank Councillor Winnington for all the work that he's done with us and supported the city over this last year during the pandemic. And we'll also be welcoming Councillor Jason Fazakali as the new portfolio holder for health and care, and there will be a number of briefing sessions with council colleagues, and CCG will also take part in those as well. So they were the 3 updates I just wanted to draw the board's attention to before there are any other questions or comments. Thank you.
Thank you very much, Jo. So, questions, comments? Stunned silence. My time to gender is not going well, you realise. We are going too quickly. It's not usually a complaint, is it, Jackie?
I thought I'd take the opportunity then just to ask a quick one about the information governance, where you normally try to get 100% of our people trained by a certain day. We were very close to it, but I don't know if we managed to hit our target, so that was the question. Did we manage to get 100% for our information governance training? It's a lot of it.
As far as I'm aware, but Justina may be able to
Yeah, it was Justina or Michelle.
Thank you, Joe. Yeah, we have a duty to achieve a 95% against that target, which we did, Jackie. And we're now going out this year because our audit committee asks for that training to be undertaken and completed by the 31st of December each year. We'll be asking that again of our staff this year, along with the conflicts of interest training. But we did achieve the 95% target.
Which is excellent. That's excellent. Just that, you know, some last year I suppose we got the 100%, but we're a small organisation that represents very, very little, and well done us.
Thank you. Okay, so we are being asked to accept this report. Are people happy to do that?
Accepted.
Yes.
Thank you very much. So, item 6, we have the system updates, and this is going to be divided up into the 3 tiers, as it were, that we've got, and is a triple act between Maggie, Joe and David. Maggie, do you want to start?
Yes, no, thank you. So I think it's really important that these 3 things are always seen together. It's not one or the other. As we know, the way we best serve the population of Portsmouth is to do so in these geographies. So I wanted to today just say a few things about the Hampshire and Isle of Wight geography. So first of all, people remember we were formally approved as an integrated care system back in November last year, and more of the white paper and potential reforms coming. But Hampshire and Isle of Wight was approved as an integrated care system in November, and that was our performance as a collection of places and geographies working together and our track record so far. I think none the least our performance during COVID. Helen's report tells that story very well of how we were able to work together across the wider geography and in our local places to best effect. And probably the vaccine programme, the life-saving vaccine programme, is such a good example of that, how some of the things we did across Hampshire and Isle of Wight, but of course people got their vaccinations, their jabs in their arms in local places and spaces in and around Portsmouth, really highlighting how both and is what this is all about. The second thing, which is in the public domain and has been reported, is also Hampshire and Isle of Wight. Again, because of our track record, we've been approved as one of a relatively small number of accelerator sites across the country, receiving £10 million of development, transformational funding to help us do this vitally important job now of improving the position in terms of long waiting lists and the length of time it has taken for people to have surgery. And we'll pick more of that up in the performance report. But it's really good news, you know, just two examples of where coming together has really made a difference to our ability to do this. It's really positive. One of the things I think we'd note is our really good performance on advice and guidance, and in the Portsmouth area, that's where we're doing really well across the patch, but also nationally. We're in the very top few across the country, and that's making a big difference to the experience that people have who need a referral. So that's where we're at. We've got a programme of work. The bit I wanted to say is a bit about the white paper. So we've got a white paper that is now going to work its way through the legislative route. There will be very shortly a whole series of guidance, we understand, from the centre, which will help us as a local CCG in Portsmouth and within our wider system, find our way through to enact the changes should they come to fruition. What's really important in the proposed legislation is the fact that there are two parts of the integrated care system now proposed. One is an NHS body, So in our context, that would be Hampshire and the Isle of Wight being a statutory body. And once that was established, subject to legislation, then the 2 CCGs that cover the patch would then be dissolved. But the functions and the duties of CCGs would be go into the NHS body. And coming right to the issue of our staff, really important that we take note of the national commitment to our staff, that our staff are protected and supported during this change. So I think that's very important. And again, following conversations with colleagues, I think we're all really committed to really making sure that our staff, our CCG staff in Portsmouth have through this huge opportunities to use their skills, their strengths, to have opportunities to work in the various parts of our system, and importantly, because of the strong track record, as we know in Portsmouth, is to be able to share some of the really great work that's going on in Portsmouth with others. The second part of the proposal for the ICS is a non-statutory partnership, which is very similar to the work that we're doing at the moment. And so there will be more guidance about what that will look like. There'll be guidance about the minimum expectation of board members and some key requirements. But I think when the guidance comes, it will be helpful, it will be national guidance, but we understand there will be a lot of flexibility, which I think we would welcome, because we want to be able to implement what comes in a way that makes sense for Hampshire and the Isle of Wight. We're on this journey. We've done some great work in place, as in Portsmouth and South East and across. We want to be able to accelerate that work, recognising that the guidance is going to be for the whole country. So there will be some must-dos, but there will be a lot of flexibility, which I think we'll be very keen to take advantage of. A major focus within this, however, which I know is important to us all, is the concept of place, and that within an integrated care system, there will be really good delegation of resources and decision making to local places. And that's for us to define what place means and how it works. And that really will be our job of work over the next few months in anticipation of any changes. But also, we were doing this anyway. We were working on this journey. So the concept of place, really important. A real focus around local authority geographies, which is a very strong message now nationally, which I think is really helpful for us. And the other concept we understand will be talked about nationally more is so-called provider collaboratives. The sense that groups of providers will be working together to better able to deal with some of the problems that we know organisations struggle to achieve themselves. And again, that will be for us to define. I think some NHS organisations will belong to multiple provider collaboratives, and our job will be to define that, be clear about accountabilities, and in a sense how inevitably what is quite a complex geography, how that all fits together, how it has very strong clinical leadership, very strong connections to our community, and how that we use all of this change, building on our work in service of improving health outcomes for our community, getting better integration, reducing the inequalities that we know exist, reducing unwarranted variation, and really learning and sharing across all our geographies. So I think the task at the moment is to keep close to the emerging views, as a CCG to be influencing the policy formulation, which we're very happy to do. And when we start to get the guidance as things emerge, then we'll be ready to move appropriately, mindfully, building on our track record and getting things right. Right for us, right for the integration with the city, and right for all our partners. So I think we're in a good place. We've got a strong track record. you know, things are going well. Going back to what Helen said, we've got to really keep this ICS development proportionate. It's only part of our work, and it is in service of being able to deliver all the things that we want to deliver more of later. So the good news is that we're prepared, and that as a board we're ready to face these challenges and do so well, safely, looking after our staff and making sure that any transition that follows legislative change we do in a very orderly manner and very thoughtfully, and get ourselves into a really good place should there be changes from April 22. So I'll stop there if I may.
David, Joe?
I'm happy just to touch on issues at Portsmouth South East Hants and Health and Care Portsmouth with Joe. Reflecting really what Maggie was saying, we're working through exactly how these different tiers are going to operate, on what's best done where, how we give emphasis to what is most appropriate at those different geographies. Clearly the footprint of the hospital is incredibly important, and our interfaces on that geography are important, but it's not necessarily the most appropriate geography to explore other things on. Some of those are better off done on a bigger geography, some more locally. We're still working hard at deeper integration within the city. Clearly we've made enormous progress with the CCG and the City Council, but we're keen to see that develop as well with other partners, you know, including the police, including the voluntary and community sector, which, you know, and all of those other agencies that impact on the wider determinants of health. I think one of the things, I mean, there's been a lot in the health press around inequalities related to COVID, but inequalities have a massive impact on health and outcomes. And I think that there's a lot of work for us to do to better share our understanding of that across agencies and in terms of how it impacts on people's outcomes in the community. Housing, for example, has a huge impact on that, as does worklessness and the opportunity to find good quality employment. I think we also need to be conscious that even at a relatively local level, the city boundary is porous. You know, the local employment and housing markets, for example, that have no idea where the city boundary is. So it's important that we work very closely with our immediate partners as well as our partners across the bigger geography. So undoubtedly we're going to hit some teething problems in terms of what gets done where. I think one of the key messages from my perspective is that we need to make sure that we maintain the focus on the needs and opportunities with our communities at those different tiers, and don't get sucked too much into the programming and program management side of things. I think the inequalities stuff will be a very good example of that. Sometimes we seem to be better at building a program to explore something than we are actually exploring what really are the issues that impact significantly on people's health and care. So I think that's probably enough for me. I think it's going well. I think we've got good relationships to build on. Clearly, we're going to have some new faces at the Health and Wellbeing Board, which will be good because they'll bring new perspectives as well. But we also need to recognise that on occasions we do use a language of our own, and we do need to help people into those agendas. Thank you.
Joe, do you want to come in at all?
Not much really to add, just that we're continuing to work really closely with our partners on all of that to ensure that we are you know, at the forefront of those developments and sort of trying to accelerate what we can. And as I said, the prospectus and our operating model, I think, sets us in really good stead for that. So that's really helpful to have those conversations with our partners at all levels and work through what's best done where.
Lovely, thank you very much. Jackie?
I suppose I'm just following on from a previous conversation that the board were fortunate enough to have, and so my voice is probably going to sound a little bit practical and a bit of a dolly downer, but it's around us being able to shape what is place and what might be expected nationally as what might represent place, and that we have got ourselves quite quickly, and I'm really pinching Carsten's ideas about quite quickly looking at what we have shaped in Portsmouth in order to deliver for Portsmouth and across the piece and to learn. So that's the bit that's I'm a bit like, I'd like to see some shape to that, so that will align with what the national requirement might be for what local needs to look like. That's it.
David?
Well, yeah, I think Jackie's absolutely right on that, and I think we've got a good foundation to build on with that, Jackie, and I think we've got that from across the city as well, because the work that we did over the last, what is it now, probably 2 years, with thousands of people across the city, as well as all the agencies and institutions and groups of the city around the city vision, not only, you know, gave us some really strong messages about how people see their city and want to see their city, but also about the values and behaviours that they expect within that city. And I do think that, you know, whilst is part of the day job, reflecting that through, you know, in terms of how we design our services, who we involve in designing our services, and you know, and how we get most for the Portsmouth pound, whichever agency or community group or whatever is spending it. So yeah, it all points to that deeper collaboration, I think, but also maintaining that focus on outcomes for people, whatever geography we're seeing them in.
Is there something about doing whatever we're doing only once at the different levels as well, so that if it is something that everyone is doing, we need to do it collectively and collaboratively across whatever geography that requires? And you know, certainly in the last year I've been involved in some regional calls, and actually, yeah, Maggie talked about vaccinations. The vaccine issues have been the same for everybody. It's not been a Portsmouth thing, a Hampshire thing, or whatever. So we need to be really cognizant of picking our target of who to work with on any one project or bit of work, so that people aren't wasting their energies reinventing the wheel. And I think that's something we need to be really encouraging our staff to look at before they launch into something. Where should they be placing this piece of work? So that feels a positive thing to me. Sorry, David, did you want to come back in, or?
Well, I think you're absolutely right, Liz, and you know, strangely enough, it's a conversation we were having earlier about the importance of our staff having the confidence and ability to work up and down the tiers and see issues from different angles in that way. But also, it's one of the things that came through explicitly from the community themselves in terms of the efficiency and effectiveness of their public services. And and there is something about us reimagining what that is. I was talking with Alison about it yesterday, but what that welfare state looks like and needs to look like for the future, and what have we learned from COVID that should be informing how we move that forward. I think it's an exciting agenda.
Lovely, thank you. We've got Margaret and then Maggie.
Yeah, so I just wanted to pick up two things. One was what you were just saying about doing things once, Elizabeth. That for me suggests that we might, in looking at reshaping what we're doing, look at streamlining all the meetings that we get involved in, so that we have people are clear about where certain issues are being dealt with, and not everybody gets into trying to deal with the same sorts of things. But we need a streamlining of meetings in that case. The second, the second point was in relation to recovery. We are trying to achieve this change at a time when we're in a recovery stage for COVID. And it's really important, the message about collaboration is one that we communicate very clearly, because I think there's a danger, and it was in some ways obvious in this morning's quality meeting, that because the system is under pressure and demand is rising, one section blames the other for what's wrong and what's not working. And when we actually need to be collaborating and supporting, finding ways to support each other in different parts of the health service. And I just think there's the current pressures are such that we will have to be shouting that quite loudly.
Sorry, Maggie, would you like to come in?
Yeah, no, thank you. Margaret, thank you for that. And I just really wanted to actually build on a few of those points, because I think it all ends up being the same thing. I think we do need to be very clear about how we're going to make things happen, not a plan for a plan. I think we do need to streamline meetings. I think, there probably is too much duplication at a time when there's so much to do. And as you quite rightly say, Margaret, our staff, both in the CCG and the council, primary care, people are still needing to recover, recuperate, reflect. And I think we just need to keep a real focus, don't we, on our people, because as the world starts to normalise, building on Helen's comment, we're sort of still optimistic but cautious. But I think as people start to relax and normalise, sometimes the pressures that they've been under for this last year start to hit. So I think overall we have a slightly less resilient workforce, slightly more frayed edges, it's still working a lot in virtual world, which just means misunderstandings can happen, and without all the adrenaline of that peak of the pandemic. So I think all of that mindfully, prioritising, really focusing on delivery before we move on to something else, keeping a real close attention on all our staff and their health and well-being, making sure their jobs are fulfilling and they're not cluttered. So I think there's a lot of themes, and it all points to the same, doesn't it? To just take stock in this, extraordinary times, really.
Yeah, and it's we've not really talked much about is that rest. The whole NHS workforce is exhausted, and the care staff, everyone has been working above and beyond for months and months, and well, as Helen said, it's over a year now, and there's only so much you can do without that pause. And while we're talking about restoration, recovery, rest has to come first, really. We have to remember that one. So, have people got any other comments or questions on this update? I think it's been really useful to air some of the concerns. I'd like to move on to item 7, which is the finance and performance reports. So this is to Michelle and Joe, with Bernie very kindly supporting, particularly for the last 2 papers. So I'll hand over to you, Michelle.
Lovely. Thank you, Elizabeth. I'll take the papers in order. Hopefully I've got them in the right order with my notes. I want to make sure I say a few things to each of the papers, if I may. So if we start with our month 12 finance position for the year of 2021, and you'll recall at our last meeting, we were talking about being on track to achieve a £3.3 million surplus. And you'll also recall that we were also playing our part in the Hampshire and Isle of Wight position alongside that. So I think about a week later, I was then having discussions about the Hampshire and Isle of Wight position and our colleagues across the piece, and how could we ensure that each organisation achieved a good position overall for Hampshire and Isle of Wight. So following those discussions, I updated you through the development board and a separate paper just to update you that our target position had changed from a £3.3 million surplus to a break-even position. And this paper that's on the board today reflects our final year-end position, where we achieved a small surplus, which when it gets rounded is rounded to a break-even position. And I'm also pleased to say that each organisation in Hampshire and Isle of Wight landed their positions in a similar bracket as well. So fantastic news for the system as a whole, as well as our own position too. Other things just to mention that are contained within the report, that we achieved the expected cash balances, and that as a CCG we performed well against all the payment processes that are expected of us. Our annual report and annual accounts have been submitted on time, and they should be finalised mid-June once we go through the audit processes, etc. And that aligns with the national deadlines and expectations. Last week, the audit committee gathered, and we had a run through of our annual report and annual accounts. One, so that people are updated as to what it looks like, but also to make sure that we dot all the I's, cross the T's, and make sure that we've reflected the work that we did as an organisation throughout what it has been a very strange year for us all. And then the audit committee meets on the 2nd of June, where we'll formally approve those reports and annual accounts. That's all I was going to say. I'll pause there to see if there are any questions anybody has. No, shall I continue? Happy with that?
Well, I will come in with, I think it's a fantastic effort that we have achieved that surplus yet again. This is, I've lost count of the number of years we've been in this position, and I think it is all credit to everyone in the team that we've got there. And I know there have been comments about a lack of challenge around our financial position, but it's quite difficult to challenge it when it's been so well managed.
Thank you.
Yeah.
Yeah,
I find it hard to know quite what more to say, but I would like to pass on my thanks to everyone for their huge efforts to maintain this excellent position. So thank you very much.
Yeah, it's definitely a team effort to get to that place. Yeah, and our integration with the councils also enabled some of that as well. So we do try and help each other out to make sure, like we keep saying, we get the best for our Portsmouth pound, don't we? Okay, shall I do a little introduction to the performance report before we go on to plans?
Thank you.
Yeah, so performance report in its usual format, trying to update the governing board on performance as it currently stands. Again, when we're trying to deal with pandemics, we're still in that major incident mode, aren't we, predominantly? The areas that we would like to highlight and bring to your attention include 111 call answering, where we continue to work with SCAS to improve the call answering times, but noting that 111 First has been introduced during the pandemic, and the number of calls has increased, and therefore, you know, they still continue to have issues around those call answering times, but they endeavour to improve throughout the months. Cancer targets, well, Graham posed a question last time around, are we achieving those targets because we have less referrals, etc. So we have re-looked at that, and yes, there are slightly less referrals, but not dramatically lower than previously. But I'm delighted to say that Portsmouth Hospitals are still trying to ensure that the capacity is put in place to see those cancer patients, and achievements against national targets is relatively good and remains so. We get the, you know, 1 month it will be subsequent 31 days subsequent surgery and stuff like that is not achieved, but it's never a dramatic reduction, and it tends to recover across months, doesn't it, in terms of our quarterly performance usually looks relatively okay. Referral to treatment targets, Maggie already has mentioned that Hampshire and Isle of Wight is an accelerator programme, receiving some funds to ensure that we focus on long waits and to try and bring down waiting list sizes as well. And as a system, we start in a relatively good place compared to others, although it's, you know, it's not great. We are trying to ensure that we restore services in a way that reduces those long waiting times, but also ensures that we receive some of the elective recovery fund, get my acronyms right, as part of the plans. We also have had one MRSA case reported in February, and we haven't had one of those for a long time. The quality team have been assured that the learning process has been undertaken as a result of that one case. And for mental health performance measures, Portsmouth CCG doing well again compared to others. However, there are a few that we need to improve to make sure that we achieve the national levels, which includes dementia diagnosis rates and improving IAPT, the IAPT, people entering treatment, where we have achieved the target in January. So we've got some good signs in that particular target. We need to make sure that we keep on top of that one. And also to end probably on a more positive note, that despite dealing with the pandemic, SCAS continue to perform well on the 999 ambulance response times. That's all I was going to say on that report today. Is there anything that anybody wanted to specifically ask?
I would like to ask Simon whether he would like to comment about the elective recovery programme.
Yes.
Are you able to comment on that, Simon?
What particular regard, Elizabeth?
Well, there have been concerns about the elective recovery and how that's being handled, and I just wondered if you wanted to say any more about it and the numbers and how things are moving forward.
Honestly, I'd have to go back and ask. I don't know specifically across the whole system.
Okay.
I'll probably pick some of that up, Elizabeth, when I talk to the 21-22 planning.
Okay, thank you. Jackie?
So that might preempt me a little bit, because it's nice to know that we're an accelerator site with an extra 10 million, was it? But I also know that we have got, like Maggie was saying, an exhausted workforce and exhausted clients, patients, whatever. And I don't know what that buys you. Does it buy you more consultants? Does it buy you, what does it buy you a new system? Given that it's just exhausting out there for everybody. I'm just curious what we get as an accelerator site and what it means.
Shall I come in, Jackie? Just help a little bit with that. So the really important thing is this extra money isn't to pay for the work. That gets funded in the way that it would normally. This money is, if you like, transformational money. And although inevitably we will have to do a bit of more work, because that's the only way you get through cases, continuing to just do more of the same is not going to be the way forward. It's not sustainable. So the idea about this, and of course we've been given this money to test some things, to experiment, to hopefully succeed, and if we're going to fail fast, and then we can share with other people. So it's using the alternative mechanisms. It's about managing the waiting times differently, managing referrals differently, looking at the way our workforce is deployed, digital solutions. So the idea is not to just do more and more and more, but to do different, so that both deals with dealing with people and their conditions and their symptoms, but also attends to our workforce issue. So that's the idea behind the accelerator money. And I forget the acronym, Michelle, but we get money through a fund, don't we, for doing the extra work. So it is not just to do more of the same. The 10 million is to pump prime our systems and our transformation.
Sounds very, very helpful and kind of what needed. If we've got alternative ways of working that are perhaps more effective and give our workforce and patient and service users a bit of breathing space as well and sustainable, I'm all for that. Thank you.
Yeah, the incentive money is called the Elective Recovery Fund, ERF. Yes, Elective Recovery Fund. Which is, as Maggie said, is different to the £10 million. So it's making sure that we capture all of the good innovative ideas that we have put in place through the pandemic, as well as piloting some other different things, as Maggie suggested. Okie doke.
Lovely. Graham, you've got a question?
Graham.
Yeah, I think in part what Maggie said is partly responds to what I was going to say, but and for RTT, obviously where the figures are concerning, that's really good news. If I take something like cancer, obviously the figures would suggest that we've had about a 10% drop in demand, and obviously we all expect there's quite a lot of latent demand that we haven't been seeing that is now going to start to appear as we come out of lockdown measures. And I think my slight concern is that and I know each pathway will look differently, but if we just restore and recover some services in the same way as they were pre-COVID, it's going to take us years to catch up some of that recovery time, so that we do need to be looking at what we can do to look at services in a different way if we're going to catch up some of that. And I was just thinking of cancer. Is the recovery and restoration looking at that in a different way, or is it effectively standing up the services as they were before, if anyone knew?
My understanding, Graham, would be there'll be a mix, as you say, depending on the pathway. I'm just wondering if maybe at our next board, on the next board development session, we bring the latest paper in terms of what is Hampshire and Isle of Wight proposing to do, and so that you get a wider understanding of what we are trying to do different.
Yeah,
that'd be helpful.
Yeah, that'd be helpful.
That's really useful. Yeah,
because otherwise we're all we're not entirely the experts in terms of what is and is not being stood up, and of course each of the acute trusts in particular are also trying to work together to make sure that they make best use of resources, so that will be part of it as well.
Lovely. We've got questions from Andy and then Linda. Oh, and Joe, sorry.
Thank you, Chair. Mine's really just a comment, and it sort of echoes something you said earlier about the effectiveness of the finance team, who have been superb given the number of changes they've gone through in the last 18 months or so. And I think that's clearly pointed out by the internal and external auditors. when we have private conversations with them after the audit committee, where they admit to looking for chinks in the armour within the finance team and very rarely find them, and heap praise on them in the most wondrous terms. And they also make the point of comparing Portsmouth and our finance team with other areas, and that's in local government and the NHS. And they come out tops every time. They really are a credit to the organisation. And I can only thank them as chair of audit for the hard work and effort they do. Superbly led and a first-class team. Thank you.
Thank you, Andy. Thank you very much. That's good to hear as an independent view as well, which is always useful. Linda.
Thank you. It was really about the elective care and recovery and obviously long waits. I think it's important to note that there will be a piece of work about appropriateness of some of these people on the waiting list now. Some people will have improved in the time, some people will have deteriorated, some people may no longer want the procedures. So there's a piece of work there. Also, we have developed new things. So I'm thinking of gastro, particularly where we do fit testing and calprotectings rather than cameras. So, you know, there is a whole piece of work to do on that, but we are doing that. And as you say, doing it as a system and looking across so that if one area has better weights than others, that we can share that workload.
Lovely, thank you. Jo.
Yeah, it was just to echo Michelle's point really, that we can bring more information back to the board or back to a development session, and that some of our, when we look at our planning, looks at how we're trying to do some of those things differently, because recognising we can't just do more of the same. And we're also working with Linda in her new clinical leader role as well, with the other clinical execs, just to make sure that we are engaged in those conversations at the ICS level, so that primary care doesn't get left behind in some of those conversations that can be quite acute focus. So we need to make sure that we have that primary care voice. Oh, sorry.
Oh, that's lovely. Talking about things to come back, I would be interested in hearing more about the dementia diagnosis rate that has dropped prior to this last year. We were always good at this, and we tended to have a higher rate than an average. I know it had slipped a bit, but we're well down, and yeah, I think it would be useful to have some feedback about what's going on specifically around that, because they are, by nature of that population that gets dementia, there are older, more vulnerable patients who have perhaps been more cautious about contacting services over the last year. So I think we need to look at what we're going to be doing for that cohort. We've still got Linda's hand up. Is that back up? No. Maggie?
Yeah, I mean, I know we all know this, but it's just making sure that this elective recovery list issue, we don't accidentally start just thinking about acute services. You know, it is the whole system, and it starts in primary care. And I know we all know that, but there's a tendency. So I think bringing it back and understanding the whole part, and as Linda has just said, you know, it's the whole, how people get referred, when they get referred, management of people while they're waiting. So it's the broad pathway that we really want to be focused on. And the other thing, actually, it's just timely to say, people will have seen just over the last 3 or 4 days or so, there's been quite a lot of I guess criticism of primary care in some of the national press, hasn't there, about, you know, has primary care just shut up shop and not working anymore, which of course, you know, we know isn't the case. And I'm sure nationally, up and down the country, there probably are some examples where people haven't been able to get hold of their GPs. But I think it's just so important that we really, really value and really recognise all the work that our practices have done, not just on COVID, but on trying to recover, the life-saving vaccination programme, which we're going to give another boost to try and really get through the next cohort. So it's just so important that accidentally we don't drift towards acute services, and we keep that, you know, I know I'm speaking to the converted, but it's so important that we keep that in sight.
Yes, and I know if Nick was here, he would be saying the pathways are the whole journey for the patients, and equally, if we are shifting work away from the acutes, the community and primary care has to be suitably resourced to do that, because currently they haven't got a lot of capacity. Margaret, and then we'll move on.
And I just think in order to do that, we have to have a more serious focus on early intervention and prevention, and that in the context of focusing that on our most deprived communities, because that's where often it's left very late before there's any kind of intervention that then becomes quite costly, both in terms of their health and our financial costs.
Absolutely, very good point and reminder. Right, Michelle, back to you for next.
Okay, lovely. So the next paper is the financial planning. Yeah, Maggie's leaving.
Oh, Maggie.
Yeah, thank you, Maggie. The next paper is an update really as to where we've got to in terms of planning for 21-22. And as I said at our last meeting, planning guidance has sort of been delayed whilst we try and work out under what sort of financial regime are we going to work to for the next year. So at this moment in time, we have submitted a plan that looked at the first half of 21-22, which is known as H1. So if you see the acronym, that's what it means. It means the first half year of any year. So the paper that you've got in front of you shows the investments that we've identified and our commitment to achieving the mental health investment standard. So we find ourselves in a similar financial regime as we did for 2021, so paying our main providers in block amounts for the first 6 months. The hospital discharge programme has been extended until at least September. However, we're still a little bit uncertain around the funding arrangements for that programme. And as I say, Hampshire and Isle of Wight has submitted a plan. That plan for Hampshire and Isle of Wight overall is assuming a break-even position. We are showing a surplus as part of that, with other organisations showing a deficit position. And we will continue to have those conversations as we go through the year in terms of how are people doing against those plans, what outcome do we think is going to happen, and have we got the money in the right places, in a similar way to how we did for 2021. So within submitting that plan as break-even overall, we do have some risks that are contained within that, and some assumption about where we might have some delays maybe in terms of investments, or where we might need to find some efficiencies. And there are also some assumptions around additional income streams or allocations, which includes the hospital discharge programme that I've just mentioned, both within our plans and within the provider plans, and an assumption about using some of the elective recovery funds. So we've talked about this incentive programme on elective work, and if we achieve what we're expected to achieve, we will get what's called an incentive and be able to access the elective recovery fund. So built into our balance position, we've already assumed a level of additional expenditure, which we believe is going to be covered by this income. And that hopefully will address recovery of the elective activity to more normal levels, pre-COVID, but also to address waiting times. And as you've heard, we're also trying to embed some of the innovative ideas and ways of working that we've seen over the last few months. The main difference to the financial regime is we have reinstated the independent sector contracts to more local management, which helps us understand the activity we're getting, and as I mentioned, some efficiency expectations, and that we continue to have that conversation across all organisations in Hampshire and Isle of Wight as well, to make sure that we're all taking the similar level of risk within our numbers. And also, again, just to reiterate that we've made an assumption about some investments that we need to make. And again, as a reminder, most of those investments are already up and running. So things like discharge to excess investment, for example. That's all I was going to say to that particular paper. Again, if there are any specific questions before we go on to our delivery plan and how we might get on with some of this work.
Dave.
My question around it is very specific to primary care and reflects on the last year and how we're going to be sort of going forward. One understanding of the system at the moment is a lot of the protection that was afforded to primary care from a financial perspective has been turned off with the start of the new financial year. And to be quite honest, that is a little bit worrying in that the ask on primary care at the moment is quite frankly is huge and on PCNs. And I'm just a little bit sort of worried about that and what might be coming or might not be coming to sort of help primary care with that. So I appreciate a lot of this is from the centre and not necessarily sort of local at CCG, but we are where we are. We're already sort of halfway through the first quarter, and there's been nothing else up that I'm aware of. But that makes sense.
I understood exactly what you said, other than wasn't entirely sure about the switching off. So unless Joe, you're aware of anything, I'm.
Well, without being specific.
So from where I'm sitting, Dave, I'm assuming we're treating you just like we're treating any other provider, and their income is effectively protected, isn't it, to at least September. So I certainly am making that assumption for our primary care colleagues too. Yeah. So unless somebody kicks me, which they can't because I'm sat here on my own.
My understanding at the moment is that sort of locally commissioned services are certainly protected initially, but sort of the national stuff like QOF and some of the national extended services are not protected, and that is specifically where I am coming from on this. I see Linda's moving her head up and down. Perhaps she understands it quite the same as me.
But don't we have delegated powers, don't we? So yes, shall we take your concern, Dave, and I would suggest as an exec we need to have that discussion to make sure it's clear to primary care what we are and are not expecting and the payment regime that sits around that.
Yeah, I'm happy to take that with the team, Michelle, because my understanding was the same as yours. Primary care was considered in the same as others for the other providers for this half of the year.
And certainly our plans assume a similar run rate to what we've had as last year. So from that point of view, Dave, I don't think there is an issue. Clearly, we need primary care to be stepping up in the same way as we're expecting others to, in terms of your ability to work within the COVID restrictions and what that means, and how we ensure we embed the different ways you've been working. So how do we enable you to do more of that as an ongoing thing, not to revert back to how services were provided in the past?
Okay, thank you.
Does that help?
It does, yeah. It's the reassuring and clarification I think that I'm looking for, and certainly my colleagues out in primary care I think will appreciate the same.
Absolutely. We need to make sure you're as efficient as possible, don't we, so that we get more for the same amount of money, as I suppose what I'm trying to say. That no, I'm certainly not going to be going backwards, put it that way.
Thank you.
Excellent. Linda, did you want to come in on that point?
Yeah, I think it was just to support Dave. I think the concern is if QOF was, say, they may well have said for the first quarter, don't worry about it, but the worry would be that in the other 3 quarters, we'd expect to do the whole year's lot in 3 quarters. I think that's what Dave's saying. So it just needs clarity about what's protected for how long, and then what we're expected to make up by the end of the year. And if we can get that sorted, I think primary care would be relieved and carry on as they are.
Thank you. Jackie.
Thank you. I was going to go back a little bit, Michelle, around the hospital discharge programme, because I noted in the paper that it could pose a significant risk to us if we don't get that funding. It makes this table look very, very different. And I could hear some of the things about how we might make up some of that, but I wondered if we had a stronger contingency, and actually whether the 7 million cumulative surplus that we have remains ours to be able to spend, or does it get redistributed, or what happens? Where are we?
I think in the first instance, we need to understand for the next 6 months what is the allocation, because that's what they're talking about now, is possibly an allocation for a hospital discharge programme, rather than at this moment in time we have a top-up process. Yeah. From a Portsmouth point of view, we're in a really good place in terms of we understand exactly who is on the hospital discharge programme currently, where they are in their journey, and what might happen to them in the future. And then it reverts back to, well, these people exist anyway, don't they? So what will be the patient flow going forward? And some of the work that we've been doing there is about how do you get home first, and how do you get discharged to assess to be embedded into the patient flow, rather than the perpetual conversation we have about people being stuck in the wrong place, stuck in the hospital maybe, rather than an onward journey into their recovery, or indeed the additional support that they require going forward. So we do need to be rapidly thinking about, if the hospital discharge programme funding ceases in September, what does that mean for our second half of the year and indeed future years? And how do we, as a system, as a place at that point, work out, do we have enough money in other budgets in order to continue the way that we're working? So yes, it is a concern, and something that we continue to work on. That's Portsmouth. The table you see includes the rest of Hampshire and Isle of Wight, and as you would imagine, Hampshire being the bigger part, there is a more significant issue that the teams are trying to work on, to understand what the ongoing cost might be going forward, and do they need other services to be stood up, which might cost more than any of us have got, but is that the right decision to make as a system going forward? So there's work streams going on to look at that, to make sure that we've got that right going forward. And in terms of our old carry forwards, Jackie, we'll be in the same position in that we know it's there. We also know that the expectation is that we break even as an organisation, or as an organisation, as a system, as an overall. So that's what we strive to do. But we're always mindful of making sure that we are doing the right thing by patients.
Yeah, and I did mean across the whole system. For once, I wasn't Portsmouth-centric.
No, that's fine.
Yeah.
But again, there is that nuance in, as a place, because of our integration journey, we have done some really good things that stop people looking at whose budget it is, and they don't look at the budget. They look at where is the best place for this client to go next, in their journey. Not worry about, is it more social services than it is health, and that we can't say the same about other parts of our Hampshire and Isle of Wight currently. People are trying to rectify that, but as well as I do, it took it's taken us on a long journey, and they're not necessarily anywhere near where we are currently.
Thank you, Michelle. Last words to Joe before we move on to the delivery plan.
It was just to pick up on that and just to reassure Jackie around how those conversations are working locally with us around how we look at where are the problems in the pathway, where are we not meeting the 6 week funding piece, and we look at where are the issues in our processes and how do we resolve those issues. It's very much a joined up problem solving approach rather than worrying about who pays. We need to get the pathway right and the referral processes right for people. Just to reassure you on that.
Thank you very much.
Thank you. So Michelle and Bernie, is it?
Yes, I think if Bernie would like to start taking us through the operational plan as part of 21-22, and Joe and I will support her as best we can.
Thank you. Can I just first apologise? I've switched my headset. I've been sat under a massive hailstorm for the last half hour. It drifted out, and now just as I start to take myself off mute again, it started again. So I hope you can hear me, and apologies if anything gets lost as I'm talking. So this plan is sort of our setting out, I think, how we're going to do the doing. In response to the national operational priorities and planning guidance that were issued at the end of March by NHS England. And I think it's important just to flag that whilst they're still set within the existing longer term strategies, like the 5-year plan, the emphasis is very much shaped by the impact of the pandemic. And it talks about how we're recovering our services, how we're supporting our workforce, how we're going to address those people most disadvantaged by what we've seen in the last 12 months. Maggie and David and Joe have discussed the guidance around the ICS development and the development of the different tiers. And I won't dwell on that too much, other than to say that this national response ask for a system level coordination of delivery, and as such the system has responded on our behalf, but we make a significant contribution towards that. And again, what this document endeavours to do is demonstrate how we are organising ourselves in support of the different tiers to meet the national priorities. Some of this is business as usual. Some of this is recovery, some of this is transformation, but almost none of this is new to us in our journey as Healthcare Portsmouth. And whilst we recognise that work about tier delivery is ongoing, this document could be reviewed as an operational refresh of the Health and Care Portsmouth ambitions, and is part of our ongoing planning and delivery of services for our population. I wasn't going to go through it line by line, but I did just want to thank a huge number of people who've helped pull this together across all of our partners. And I was going to kind of leave it open to questions at that point, other than I'm asking formally for the governing board to endorse the approach that we're taking.
Lovely, thank you, Bernie. I'm sure by the rate of this afternoon, there will be questions and comments to be made. Having said that, it's all gone quiet. David.
Yeah, I'd like to echo the thanks, because clearly a huge amount of work has gone into this. And I think, and I don't know how much straitjacket there is around the approach with this. I don't pretend to understand that. But I guess one of the things I think we should look to do for future years, and I think this is something for us to do, through the Portsmouth Health and Care Exec, is to make sure that when we've got 60 pages here, haven't we, that's reminding us really why we're doing the doing. And I think because of the grain to which we go to with these things, I think it's extremely easy for us to forget some of the fundamental issues that we're trying to address across our community. And I think that's something, you know, it's for the CCG, it's for the council, it's for our other partners, you know, and also to raid the JSNA as well, in terms of trying to put together a sort of compelling infographic that just reminds us that whilst we might spend a lot of time worrying about unwarranted variation in service delivery, we also need to spend considerable time worrying about inequalities in our community and how they impact on health and care outcomes. And you know, and I think you know, part of my challenge is to take that message to, you know, to other fora, because, you know, it's very similar at Portsmouth South East Hants, and you can see that, you know, people have, you know, put a huge amount of work into these documents and these processes, and yet it's very easy for us to lose sight of some of the fundamentals that we're working on. And we've got them documented in huge levels of detail elsewhere. Yeah, but I just think there is a little bit of something there for us to perhaps have a crack at that. And one of the other reasons why I think that's going to be so important is because, you know, at the moment we're seeing a lot of roll forward of existing budgets and so on and so forth. But, you know, in a year or so's time, when those decisions are being taken at the ICS, it's going to be really important that we've got our act together in terms of the voice and the needs of Portsmouth to make sure that we can get that message over, so that, you know, we're ready there and we've got a compelling narrative about what the needs of Portsmouth are. Hopefully we will be able to do that. Thank you. I've had my rant now.
Thank you, David. It is more joining the dots stuff, isn't it? That's what's needed in a way. Yeah. Thank you. Dave.
I just wanted to sort of reflect on the PCN element of this document, and I'm sorry, but I'm going to be saying things that I've previously said at other meetings. There is a great emphasis on PCNs and on what PCNs will do going forward. But once again, I see, you know, a lot of emphasis on the ARRS scheme and, you know, looking to utilise that to its maximum. Personally, and I know some of my colleagues were, we were very disappointed when we saw the guidance for this new financial year around those schemes in terms of it is entirely focused on the clinical roles. There's nothing in there to help PCNs work on their management and their infrastructure. So I personally feel that really limits how far the ARRS scheme is going to go, and to ensure this is, you know, not, you know, just a strategic objective. I'm really keen to hear what practical support there's going to be for PCNs to realise that, you know, that goal, because as things stand at the moment, I don't think they will. And if I can just add one sort of minor point, well, it's not a minor point, it's quite a big point with those roles at the moment, is that the funding is paid to PCNs retrospectively for those roles. So as PCNs develop and take on more individuals, that's pressure on practices and the PCN themselves to fund up front those roles. I think it would be a lot better for PCN management if, for example, we were paid up front and then a reconciliation process was done later in the year if there are any gaps in those roles. It's a suggestion, and I think it would help the system. Thank you. I hope that makes sense.
It does, and certainly a question from me is, how well have the ARRS roles been taken up by PCNs? Do we have a feeling of that? Joe, you've got your hand up. I'm wondering if you're able to answer some of these questions. Hopefully you are.
I'll have a go. So to respond to Dave, I think there's lots of things we need to do practically to support PCNs. I agree with you that the ARRs focus on the clinical roles, not the management and the infrastructure in for PCNs. And there's a huge amount of that PCNs need to be doing. And they've also had to take on vaccinations this year, which has taken on a huge time and task for PCNs. So I think that, in answer to Elizabeth's question, that has impacted on PCN's ability to think about those AIRs and taking on those clinical roles. And we know that there is limited flexibility around that. So I will certainly let Michelle answer the question around whether we have any flexibility to manage the payment mechanisms, but where I think we need to do as a team across sort of primary care and the transformation teams, but also thinking about our wider city executive and that health and care executive, is think about how can we support primary care and practices? How do we use PCN CDs in the most effective way? We have a really good wealth of GP and primary care leaders in our CCG clinical executives, in the PCN CD clinical directors, and in PPCA clinical directors as well. But it's a finite resource, and it's really important that we don't waste that resource by people having to go to duplicate meetings and all have a different view. So we need to get better, I think, at how we use that resource and create capacity within that resource we've got. Think about how we can be engaged as a voice for primary care in the city and all the different forums around transformation that we need to be, but also how we create the capacity within the CCG clinical execs, within the CCG, within PPCA and in PCNs to provide that support. And we're starting to have conversations in the team around how can we look at our existing resource and work that differently to better support PCNs, both in terms of skill mix and expertise. And we're starting to have those conversations, with PCNs and the wider practices to better understand what support they feel they need, because there's no point us just deciding what they need. We need to have that conversation with them. So I think I don't have all the answers yet about what can we practically do to support PCNs, but we absolutely need to be having that conversation with you and recognising that primary care resilience and having resilient, robust primary care services in the city continues to be at the heart of our strategy. So we need to really refresh that and think about what it means now and how we improve it.
Lovely, thank you, Jo. Michelle, then Margaret.
I probably won't be able to answer the question about how we influence the payment mechanism, but I think we are probably in a good place to have a conversation about the way the ARS is being imposed in terms of a top-down approach. Or maybe we need to say, actually, we don't need those. We need these. Give us the money for these instead, and we'll provide with you a more resilient primary care. So how do we have that conversation? And off the back of what Jo's just said about how we're trying to rethink how we support, it's also about how do we galvanise the PCNs that we have in our patch to push back a little bit, because if we don't need those sorts of people, because we didn't need those, we needed something else. Let's have that conversation. I think that would be a better way of pushing forward our place as well. And then that's my personal view. And then linked to that, maybe how do we reset some of the other processes and payment mechanisms that we have for you guys, Dave? So you mentioned the locally commissioned services. How can we revamp that so that we get the right thing and more resilient providers and better services for our patients as a result? And then looking to that prevention part of our agenda that we never quite get to, do we? We always seem to do it sort of piecemeal rather than actually, could we do this in a completely different way. That would be my view. But in the meantime, we'll try and see what we can do about the current mechanisms and see if we can get that more sense, more sense into it to make sure it gets off the ground. If that's what we decide, that's what we do need. I ran a bit there, sorry.
Thank you, Michelle. Moving on, we've got Margaret, then Graham, and we will try and close things down with Bernie's last words after that.
My only comment is to back up what Michelle's saying. I think primary care networks have been asked to do too much too soon, and so we need to find ways of, in some ways, focusing on maybe a few practices to do certain of the outcomes, to achieve some of the outcomes, or at least to generate some evidence about what works in some cases and what might not work in others, to try and slow down the having to ask everybody to do everything, which is just crazy. So I don't know how you do it, but there needs to be a way of, in the reshaping, of not asking quite so much in quite such short timescales, and generating more evidence that practices can be confident in that what we're doing works for them. So I don't know how you do that, but we need to try.
We'll stack that away and bear that in mind. I think, Margaret, it's a good point. Right, Graham. Oh, and Carsten wants to come in, so take Carsten's point as well. Graham.
Just a couple of points, just to say, probably outside of this meeting, if I just catch up with Joe and Bernie around the workforce bits, because I think we've mentioned during this meeting about our concerns around workforce, and I think we've got REMCOM coming up in July. It'd probably quite nice if we could take the workforce part of this plan and just develop that out a bit, and take that into REMCOM in July. The other observation was we also spoke a couple of times about health inequalities, which are obviously in the front part of the plan. And again, it's not a comment about the plan itself, but I think it's just about some of the things we're talking about, like health checks, etc. How we might be, needing again to look at how we might deliver those in a way that isn't the normal way to actually reach those communities that we know we're struggling to reach, because again, doing some of the things in the same way we know is not going to reach those communities in the same way it does others.
Very good point. Thank you, Graham. And certainly we can take the workforce stuff and work that up. I think that sounds good to go to REMCOM. Carsten.
Just a quick one. I think it's important that we also formally organise the PCNs. It seems that the hospital.
Carsten, we can't hear you.
Can you hear me now? Sorry. It's can you hear me?
It's got a funny feedback, Carsten. I don't know what's.
I don't have it. One second. It's important that we organise the. Can you hear me now? Can you hear me now?
Sorry, Carsten. Can you put what you want to say in?
Yes, you might be able to hear me now. It's just that important that we organise the PCNs in a sort of formal way. I fear that the PCNs are sort of being left to deal with stuff they're on their own. They're given incentives in terms of DESs and LESs, but the hospital's got their ducks in order. The community is sorting themselves out. ICSs are being put on a formal standing. ICPs are being formed, but PCNs seem to be at the center of some sort of delivery program, and I fear that we're not we're not there. Yeah, we're not being looked after well enough. Yeah, I mean we're always considered, but I think the actual because I think that there has to be some sort of formal statutory type of activity as well for the PCNs, because I don't think letting the practices sort their own stuff out will get these programs finalized or going. You know,
that's something you can answer to, Joe.
Yeah, happy to. I would agree with you. I think in Carsten around there are some risks around some of the new legislation and the white paper about how PCNs and how primary care voice is heard in the ICS and at all levels, so that we maintain that in the way that we have under CCGs. I don't know whether there will be any consideration around statutory roles for PCNs. However, I think we have to do what we've always been really good at in the city, which is work together at a city footprint and at PCNs and locality level. And I think we are very aware, I think we've had this conversation a number of times, and as a team, primary care resilience is going to be a huge priority for us over the next few months, next days, next weeks, next month. And we absolutely need to do all we can to work with practices and PCNs and the PPCA and yourselves as clinical executives to think about what can we do in the city, what do we need in the city, how do we continue that to ensure we have vibrant and sustainable primary care in the city. So I don't have the answers as to what we do, but we're absolutely starting to have those conversations with clinical leaders in the city and to make sure that we give you the headspace to think through what can we do differently, how can we build on what we've got with PPCA, what makes sense to be done at a city level once, because it doesn't make sense for the PCNs to recreate the wheel, and how do we support PCNs to support the practices and ensure that they retain, maintain resilience as well. So that I'm very happy to bring further updates on that back to the board, because I think it is really important and it's got to be a big priority for us moving forward.
Definitely. I think Dave, you would agree with me, isn't it, that the PCNs need strengthening and need need a very sure footing to be able to fulfill the future demands. I'm convinced.
I do agree with you, Carsten. I think perhaps what I understand why it's out as an extended service, and in terms of what the PCN is as an organisation for its initial concept, but I'm not sure that's moved on. And secondly, I don't think quite realise that a lot of the people who are involved in standing up the PCN and getting the services going are also running a GP practice alongside that, because there's no extra resource in the system to allow you to do that. And I think that's fundamental in ensuring the potential for PCNs, because they have got a lot of potential, is actually realised. And I think that's a very important point.
Thank you very much. Bernie, did you want to come back and sum up at all, or are you content? We've had a broad-ranging conversation and hopefully James captured the salient points.
Yeah, I just want to say thank you. There's been some really useful feedback. There is nothing compelling about a 60-page document. It has been constructed with a specific ask in mind, but the feedback's really helpful. And the important thing that I've heard is actually how we support the delivery of the right thing in the right place, and ticking a box and writing a paper. That's for someone like me to worry about. And I'm sorry it was so long.
We'll let you off this time.
Thank you.
But thank you very much there's a huge amount of work in it, and it's really useful seeing it all in one place, to be honest. So thank you very much, and thank you for coming along to the meeting. So we are being asked to accept the first three papers and endorse the approach in this last paper. Are people happy, having had the conversations around these papers, to do that?
Agreed.
Lots of nodding heads. Lovely. Thank you very much. So we now move on to item 8, which is the Quality and Safeguarding Report. Karen.
Yeah, hello. Thanks, Elizabeth. The report that you've got in your pack was discussed at the Quality and Safeguarding Committee in April, so sort of contains information from February and March. Obviously, I can take questions from that. I just wanted to update the board on the discussion, a couple of points that we raised today at the Quality and Safeguarding Committee that was held today. With regards to PHU, as I think most people know, but they're currently under significant pressure and challenges, and they have been for the last 3 weeks or so. They're currently full with all escalation beds open. This is clearly symptomatic of the whole system pressures, but it will inevitably have issues for an impact on quality in the future. Also around PHU, in regards to the COVID nosocomial infections, a patient safety team have designed an investigation tool and panel view process to enable learning from such infections. A weekly multidisciplinary panel has commenced with representatives from the military and Fareham Gosford South East Hants CCG commissioners to support this work. And this will ensure a reliable retrospective review of the impact of coronavirus on each patient, which I thought was worth the board knowing. From Solent's perspective, they're reporting an increase in activity across all services, but from a quality perspective, services are safe and manageable. That's how it's been reported. With regard to our residential and domiciliary and care homes, there's no current COVID outbreaks in the homes. The CCG quality team are now refocusing on pre-COVID activity, which is good, so that the work around Champions and Restore 2 has recommenced. There is, however, a lot less people going into our care homes, and there are concerns that we're going to see provider failure because of that reduction. There's a sustainable placements project group that's been set up and is developing a short-term strategy which will focus on 3 stages. But basically what we do now in the next 6 to 8 months around this, to developing a commissioning intentions document, and then thirdly, how we work with the market once we introduce a dynamic purchasing scheme. We are talking as an ICS level to address this position. Finally, the other thing I wanted to just bring up is around the Practice Plus group, who they deliver our urgent treatment centre at St Mary's, and we had quite a discussion this morning about them because although they've returned to business as usual, although nationally contracted reviews are still on hold, there is, however, high demand for their service. The service has exceptionally reported to the CCG on 3 evenings towards the end of April, May, around increased activity levels. And although this didn't lead to a closure to walk-ins on these occasions, they were asking the 111 service not to refer or to book patients after 8 p.m. There are a couple of issues impacting on this. This is around staff vacancies, which have been quite long-standing, but also the system pressures that we're talking about within PHU as well. The Practice Plus group are working with the CCG to review their business continuity plans, and they're part of the Operational Resilience Group now, which is also trying to support them to align with the system. But obviously that's of great concern. That's our particular concern, I think, from a quality and safeguarding perspective. I think that's probably all from today's meeting that I wanted to bring up. I don't know if there's anything from the existing report.
Lovely, thank you. Have people got any comments or questions? Jackie. You're on mute, Jackie.
Sorry, I think I'm going to hit it and I haven't. Probably got a couple of things that link to what you've been saying, Karen, and also a conversation I had with Joe on the comms where you've got a system pressure, strain across all systems, and people may be inadvertently getting pinged between systems, also equally unhappy. It's just a very tired, done, worked and exhausted system across the board. And one of the things I suppose that I noted was that, like, there seem to be differences between what we might call a medically fit for discharge or a medically optimised for discharge, and whether this was causing that sort of thing might cause a bit of a wind up, who then does get to be released from the hospital to where, to when, to what, and what the actual difference might be.
I can sort of tell you the difference between those two. Certainly medically optimised assumes, I think, that somebody is fit enough to continue to receive treatment in a different environment. Whereas fit for discharge means that they're fit to go home and don't need continued treatment. I don't know if that's necessarily causing the systems pressures. That's not what we're picking up. I think Solent were having a particular issue because people were being transferred from mainly PHU into their services for continued care. I don't think they're necessarily the same system pressures that maybe somewhere like the UTC is picking up, or PHU.
That's
answer
very
your question.
Yeah, it does in part, because I wondered if it's those sorts of who are we supposed to be getting, who are we not supposed to be getting, what are we calling them now at the moment? Has it been changed to something else? It's a kind of stuff that feeds frustration.
I think that's something that's hung around for a long time. It comes out of it's been around for a while. I think we're just starting to hear about it.
And the other quick one then that's really helpful then to me is around just even the numbers across our performance report and the safeguarding report for the 52 weeks wait. There seems to be two different sets of numbers, and again I don't know if this causes frustrations, but in your QSEC report I think it's something like 2,722, but in the performance report it's 2,686 for the same reporting time. I thought so.
Probably, I think ours is slightly delayed, Jackie. Just like I said, ours is often February. If we're hearing it in April, it could be February or March that we've had our information from. So ours might be behind.
It might be worth triangulating some of this stuff. Just because it doesn't look on paper like you both seem to be quoting the same time reference, the same time period, the end of February, but there's two figures, and it makes a big difference when you're looking at 52-week waits as to how much I'm panicking or not, or how much the system or what the system's responding to. But I understand.
I tend to go with the performance one because we tend not to look at whilst the performance information is within the report, we tend to look at the quality, the impact on quality. So I would probably go with the performance report and accept that ours might be slightly out.
Thank you. The quality is always there, but I just hear the frustrations of a very tired system, and we need to be working together differently, I think, if we're going to provide this. Thank you.
Jo, did you want to come in there at all?
It was just on Jackie's point, and I guess it is, we have got, as we said, a very tired system, and we're seeing increase in pressure in demand across that system. So absolutely, apologies, it's my doorbell. Sorry, now the dog's barking as well. Apologies. But you're absolutely right, Jackie. We need to continue to work together at all levels to resolve that and have aligned communications as well, so that we're not bouncing people around the system, because that would be the very worst thing that could happen. And as we discussed earlier, we're doing lots around to manage that. And also the medically fit for discharge piece. I think our teams focus on need and getting people out of hospital as soon as possible to the right place, rather than perhaps focusing just purely on the numbers and getting into arguments about the numbers. So just really wanted to reassure you on that. The delays in hospital do contribute to the pressures at the front door, but through the Discharge to Assess programme, we're absolutely focused on trying to move people through the system appropriately as quickly as we can. So it's just to reassure you on that point as well.
Lovely, thank you very much. Any other questions about the quality report? I think it's certainly worth making sure that whoever assembles this report gets those figures aligned for the 52-week waiters.
The other aspect, just to remind people, sometimes in the performance report we talk about Portsmouth CCG waiting times. So I don't know that that is the problem here.
Whatever, we need to have
differences,
really, don't we? Yeah. Or be explicit why it's different.
Yeah.
Right.
It would be good.
So we're being asked to accept this report and note its contents. Are people happy to do so? Lovely. Thank you. So moving on to item 9, governance matters. We've got the work programme for the coming year, which is mostly what we've done before with some additional inputs which have been highlighted. So it's a resurrection of the Joint Commissioning Board and an explicit statement around procurements, business cases and decisions and reports that we may be asked to review as and when. Are people happy to accept this revised work programme? Have you got any concerns about it? No. Right. Lovely. Thank you. So we accept that. And then as part of the governance review, one of the recommendations was a revised front sheet for papers to be brought to board with some to try and bring a little bit more clarity about things. Sorry, Jackie, your hand is up, or is that a legacy hand?
No, it's a too late hand. I was going to stay with the.
Oh right, sorry.
No, it wasn't. I was slow. With the board schedule, I ask every time whether there could be something about patient experience, patient story, something. But I don't think it's necessarily within here.
Right. I know we looked at it. We started to look at it 18 months ago, and then the pandemic hit. So we started to explore it. One of the issues we were coming up against is we don't get that patient exposure for ourselves because we are a commissioning organisation, and that was one of the difficulties in finding that. We have to go to providers and it's all third hand, as it were. So that was a limitation. It's not a reason not to do it, but it is a limitation, bearing in mind we are a commissioning organisation. So we don't have direct contact with patients. However, I will take it away and Justina and I will have another look at it. I don't promise any great things, bearing in mind we're still in pretty busy times, but we will review it.
Thank you.
So can I go back to the cover sheet? Yep. So the idea of this cover sheet is to try and make it more straightforward as to what the paper's for and where it's been before, and comments about it. Are people happy with it? Lots of nods that people are happy. Should we give it a go? And if we don't like it or we think it's missing something, we can always change it again. Okay, so we will ask people from now on for the next board meeting that this is the cover sheet that is completed moving forwards. Thank you. Item 10, minutes of other meetings. We have Primary Care Commissioning Committee from January and Audit Committee from December. Do those two chairs have anything particular to say about these minutes or any points they wish to raise? Otherwise, we're asked to accept them. Some nice nods going on. So we do a rapid gallop through to item 11. Date and time of next meeting in public will be Wednesday the 21st of July at 2 till 5. Again, it will be streamed online via Teams unless things have dramatically changed. But as Helen was saying, we watch the space as to whether the world is that different by then. Thank you very much. And that brings our meeting to a close. Please, can you end the recording?
Yeah, I'll do that now. You'll still be audible for a couple of minutes, so I'll let you know when it's stopped.
Lovely, thank you.
This is where politicians say something